going to speak for about half an hour or so, explaining about secondhand smoke exposure in Scotland, and I'm assuming a level of knowledge, but I've got a handful of slides at the beginning just to make sure that everybody understands about SHS, secondhand smoke, and it would be the ways that we measure it, etc. So that's a sort of overview of the next half an hour. I've got a single slide explaining about SHS and the health effects of secondhand smoke. I've got a single slide as well about how we measure it and the impacts of smoking on indoor air quality. I'll then make sure that everybody's aware of the kind of history of all of the measures that we have implemented over the last of the 19 years. So we're almost at the 19th anniversary on the 26th of March. It will be 19 years since we implemented really world-leading legislation around SHS exposure and smoke-free environments in Scotland. Slightly after Ireland did, but we were certainly in the vanguard of that. I'll then move on to just explaining a little bit about some modelling work that we've been doing here at the University of Stirling over the last 6 months or so, and the numbers there are actually very interesting about the environments where most SHS is inhaled, and so that will make up most of the talk, and we'll have a think about the dose of SHS exposure that happens in various microenvironments. I've then got a handful of slides about exposure of the NHS workforce, especially in relation with the exposure that happens in homes. I've then got a single slide that will just explore a wee bit about the bill that is happening at the moment that all of you will be aware of, but I'm very aware that Sheila will say more on that at the end as well. And I'll end up just exploring some other next steps that I think Sheila said there were a bit on the radical side, and I'll be really interested in everybody's opinions about that. And I'll mention a wee bit as well about the SHINE network, which is the Smoke-Free Homes International Research Network. So that's an outline of everything I'm going to explain about over this next half an hour or so. So SHS, secondhand smoke, is made up of mainstream smoke and side stream smoke. Mainstream smoke is that exhaled smoke, and side stream smoke, if we go back to that last image, side stream smoke is the smoke that you're seeing in that image there off of the lit end of the cigarette. And SHS is made up of more than 4,000 of the chemicals. Obviously we're not able to measure all of those in air, and that's one of the things I'm going to explain about in a wee minute. But at a worldwide level, the evidence is that the exposure of to SHS, not active smoking itself, but the exposure to SHS leads to about 1.3 million individuals losing their lives early every year. And if you think that malaria is estimated at about 500 up to 600,000 of the deaths a year, it gives you a sense of the scale of the issue at a worldwide level around SHS exposure. Our last estimates in the UK were in advance of the smoke-free legislation that arrived in 2006, and at that point it was estimated that there were about 800 of the deaths each year in Scotland, and of the order of about 10,000 of the deaths each year in the UK as a result of SHS exposure. Obviously, we've done very well in lowering SHS exposure in the UK, in Scotland, and it's likely that number is now markedly lower than that. But still, if you look at the table over on the right hand of the side there, it lets you see the increase in the risk that you get of these 4 major illnesses as a result of SHS exposure. And if you live with an individual who smokes in the home, we see these numbers on the right hand side there. So that's an increase of about 25% up to the 50% of these four major illnesses. And I think one of the other items I'd like to highlight out of this slide is that if you're under the age of 16 and if you live along with a person who smokes in the home, it's also much more likely that you end up as an adult who smokes, and then you suffer the illnesses and the early loss of life that we see as a result of being an active smoker. And I guess we should always be aware of the fact, that 2 out of 3 smokers will die as a result of their smoking. So that's SHS. I've been very lucky over my working life in that I've been interested and actively involved in the measurement of SHS. I first got involved in measuring aerosols in the workplace. I was interested in occupational health as I worked at the University of Aberdeen, and I first got involved in measuring aerosols in the workplace and then moved on to measuring SHS exposures in the workplace in 2005. So I've got some expertise. I've been measuring in various microenvironments, either in the workplace or vehicles or homes or outdoor areas. I've been doing that now for about 19 and a half years. So no safe level of SHS. I mentioned in the last slide that there are about 4,000 of the chemicals in secondhand smoke, and one of the main ways that we are able to measure an indicator of SHS levels is either by looking at the PM in the air, so that would be the particulate matter less than the 2.5 microns in size. And if you look at the hair over in the right hand side there, a hair off of your head has got a width of about 70 microns, and I guess what we're measuring here as an indicator of secondhand smoke exposure is the PM less than 2.5 microns. So that would be the red dots that you see there. And in essence, that's the invisible soot in the air that we get as a result of burning anything. And most SHS is invisible, so most of the mass of secondhand smoke is invisible. So if you think back to that opening slide, that smoke that you were seeing in that image there, that was the very small amount of SHS that is actually visible off to the eye, but most SHS is invisible. So there are no workplace exposure limits. We're not able to use any kind of legal limit around SHS. There's no single substance out of the 4,000 of the chemicals that we can use. But something that we can do is that we can use the World Health Organization limits for both indoor and outdoor levels of PM, and set in the September of the 2021, we've got the WHO limits now, which are 5 of the micrograms in a cubic meter of air as an annual mean, and it would be 15 of the micrograms averaged over one day. So they're the kind of limits that we're able to use, health-based limits that we can use as we're looking at SHS exposures in air. Other ways of measuring SHS, we can also look at nicotine in air, and we can also measure something that is a metabolite of nicotine in saliva. And I'll mention a wee bit more about that as we go on to some of the data that exists in the Scottish Health Survey and other SHS. So the instruments in the middle there are some of the instruments that I've been using over the last 19 years to measure SHS, the sideback instrument, and it would be the Dialos instrument, and now a low-cost instrument. It would be known as the Purple Air instrument. And all of these simply use a laser inside to look at the size and the number of the particles in the air. And the graph on the right hand side there is an example of an output out of an individual's home. And we've measured the amount of PM in the air, and we see that that very much matches up along with the smoking that's happening in that home. So that's the sort of levels that we get into the hundreds, maybe up as high as 1,000 of the micrograms in a cubic meter of air. So a wee bit of the history. Most of you will be very aware of all of this, but just to make sure that we all understand the various measures that we've had in Scotland since about 2006. So the 26th of March of 2006, we had a new law in Scotland that essentially meant that you weren't allowed to smoke in any indoor space, most indoor spaces. So that was workplaces, that was the hospitality sector, that was being in a restaurant, it was being in a bar, it was being in a bus, it was being in a workplace. And that obviously had a really big impact on SHS exposure almost overnight. And I'll explain a bit more about that in a minute or two. So we move forward to it would be 2014, and that's the next major measure, and that was mass media work. It was the Take It Right Outside work that many of you will have been aware of, many of you may well have been involved in, and in essence that was a global of the first set out by the minister, set out by the government in Scotland, and in essence we wanted to make sure that the number of kids exposed to SHS at home was halved. So the value in 2012 was that about 1 in 8 of the kids were exposed to SHS at home, and the aim was that by 2020 that figure was halved and it was down to 6 in 100. And actually that was achieved, and it was achieved early. Next major measure was the smoke-free hospitals, and then the 15-metre law that many of you will be aware of. So the first one was a policy, and that was implemented in April of 2015, and then the law itself arrived in the September of 2022. And in the middle of all of that, we also had a ban on smoking in the cars if anybody under the age of 18 is in the car, and that arrived in at the end of 2016. So we've gone a long way in lowering non-smokers' exposure to secondhand smoke at the population level. A lot of information on this. This is mainly out of the Scottish Health Survey. We have really good information in the annual Scottish Health Survey around SHS exposure, and it goes way back to 1998. And if you look at the green bar there at 1998, we were seeing that only 1 in 8 non-smoking adults had no SHS exposure. So this is that sample of spit I was mentioning earlier on, that you can measure a metabolite of nicotine. And if we go back to 1998, only 1 in 8 non-smoking adults has no measurable exposure there. So 7 out of 8 non-smoking adults were being exposed to SHS. I guess you move forward, smoke-free legislation arrives in 2006, and by 2016 we see that 4 out of 5 non-smoking adults now have no measurable exposure, and only 1 out of 5 non-smoking adults have measurable exposure. So we've gone a long way there in lowering SHS exposure. And I guess the black line there is the average level of exposure as well. So not only are we seeing that only one in 5 adults have evidence of exposure, but the levels of exposure have gone down as well. So we've gone a long way. But I guess we're not quite there yet. So obviously, I'm emphasizing there that we've got 1 in 5 non-smoking adults still have that evidence of exposure. And that will be mainly as a result of either living with a smoker who smokes in the home or occupational exposures. But what we also see here, and this is essentially the same information, except also, so we've got the blue bars are the fraction of non-smokers who have measurable SHS exposure, and that's adults in Scotland. And we would see the same if we looked in England and Wales. But interestingly, we also have some information out of England, which is very interesting. In England, they also do that saliva sampling in those under the age of 16. And we can see here that there's a bit of a gap that opens up. So as we get to the latest information that's available, which would be 2016, actually we see in Scotland that less than 1 in 5 non-smoking adults have evidence of exposure, but 1 in 3 of the kids in England have evidence of exposure. And it's quite likely that that gap that has opened up is as a result of home life exposure and exposure in the home. So we've got a lot of information on the who and the where and the when of SHS exposure in Scotland. Really rich information out of the Scottish Health Survey, as I say. But something that I think is very interesting, and it's something that we see a lot in the social sciences, is this idea of the street light effect. So we look in the areas where it's easiest. And I think that this is what's happening around SHS exposure. So we find ourselves working or staying in the spaces where we find life a bit easier, rather than in the places where we know that we ought to be. And I'm going to let you see 3 or 4 slides that I think explain that we need to have more of a focus on home exposure in the home, and that these other microenvironments that we've had a lot of focus on, like hospital entrances and inside of vehicles, all of them have merit. I'm not saying that they do not have merit, but I do think that we have ignored one of the major microenvironments that we really need to be focusing on. So where should we be shining the light on? And I think the answer here is that we should have a focus on where most harm as a result of SHS exposure, where does most harm occur? And harm is linked into dose, so it's linked into the amount of SHS that is inhaled. And we should be interested in the population harm that is happening. And that's a very simple function, and it's a function of the amount of secondhand smoke in the air. It's a function of the amount of the time that people spend in that environment. And it's also a function on the breathing volume. So if you are exercising or active in that environment, then you will be inhaling more air. And I guess you add on to that, if you're interested in the population of the dose, you add onto that the number of the people that are exposed in that environment. So have a think of those 4 factors as we look at these next slides. So I mentioned earlier on that I've been extremely lucky in that I've been doing measurements of SHS over the last 19 years or so. So the bars on the left-hand side are measurements that we've been involved in making in Scotland. So if you go back to measurements that we made in the hospitality industry inside of bars in advance of smoke-free legislation in 2006, we found that the average level of SHS in bars was 189 of the micrograms in a cubic metre of air. Very high amounts, and that was averaged over about half an hour up to 1 hour in those bars. Inside of vehicles, so we did some more work, it would be about 2007, and we looked at the levels of SHS that you would measure over a journey inside a vehicle where somebody smokes. And the average level inside that vehicle was about 77. Inside a home where individuals are allowed to smoke, the average level averaged over a week is about a third of that level. So it would be week average levels of about 25 of the micrograms in a cubic metre of air. Now that seems low, but you have to understand that that's averaged over many hours. That's averaged over a week. So in the middle of the night, as nobody's smoking, the levels go down and we get obviously much lower levels. So these are the average numbers that we get in these indoor environments. I've also made measurements in outdoor environments as well. And as you would expect in Scotland, Scotland's often very windy, and we have good air movement outdoors. So we tend to see that the levels of SHS outside hospital entrances where individuals smoke, the levels there are actually quite low. So the smell is there, and yes, you experience exposure as you walk in an entrance if somebody is smoking at that entranceway, but the levels of your exposure are actually going to be very low. And then as we move over onto the right hand of the side, the World Health and the guidance, as I mentioned earlier on, averaged over a year. The World Health Organization say that you should not be exposed to PM levels of more than 5 of the micrograms in a cubic metre of air. London has ambient air, mostly as a result of vehicle emissions of about 8 of the micrograms in a cubic metre of air. If you live somewhere in Southeast Asia in a big urban environment, then your annual average exposure is going to be much higher and maybe as much as 100 micrograms in a cubic metre of air. So bear those numbers in mind, and then have a think about the next item in that equation, about dose. So how much of the time are you spending in various microenvironments? And most of us, the average adult, will spend about 8 hours at home asleep. We'll spend about 8 hours at home awake, and we'll spend about 6.5 hours in other indoor environments, mainly in the workplace, but also some leisure settings as well. And we spend about 1.5 hours of our day in outdoor environments. So bear those numbers in mind. And then also, if we're interested in the population exposure, so if we're interested in how much SHS has been inhaled in various microenvironments, then we've got really good information from the Scottish Health Survey about adult non-smokers and where they say that they are exposed to secondhand smoke. Small numbers say that they're exposed in their own home, living with a smoker. Small numbers again, 4 in every 100 say that they experience some exposure in others' homes. Small numbers in the workplace, either in the hospitality industry, often in outdoor areas of the hospitality industry or other work environments. A lot of this is about work entrances as well. So I could indicate that I'm exposed to SHS here at the University of Stirling. I walk in the main entrance way, and very often it would be a number of the students are smoking at that main entrance area. So it could be, if I was answering in the Scottish Health Survey, I would say that I'm being exposed in the workplace, even though I'm mostly in my office, which is a smoke-free environment. And I guess the main area that most most non-smokers say that they're exposed is in outside areas. And then we get about 1 in 100 non-smokers saying that they're exposed inside vehicles. So we have really good information around the where of exposure. I guess we use all of that information and we use all of that in a model to have a think and a look about where is most secondhand smoke inhaled. So 4 out of 5 adults say that they're not exposed at all, and we've got objective evidence saying that they are not being exposed. That measure of their spit and their measure of the metabolite of nicotine, But of those who are exposed, where are they being exposed? Where is that exposure happening? And if we use those numbers I've just explained over the last number of slides, here's what we get. It lets you see the fraction of secondhand smoke that is inhaled at a population level in Scotland by setting. And almost all secondhand smoke that is being inhaled in homes. So 96% of secondhand smoke that is being inhaled is happening in homes. Most of it in our own homes if you're living with a smoker. A small amount of it as you visit others' homes and you're being exposed to SHS there. A fractional amount is happening in the workplace, mostly in those entranceways as you walk in the door and you're being exposed for seconds. A small amount in other outside areas and a small amount in vehicles. But really the elephant in the room here is that most SHS exposure happens in home environments. And so I'd like to just have this slide up here as well. This is a survey of, I think it's over 400 adults in Scotland, smokers and non-smokers, and asking them about the policies that they see as being acceptable or unacceptable. And over in the box there on the right hand side, you can see the levels of the support for a ban in homes, a ban on smoking in homes where anybody under the age of 16 lives. And 67 out of every 100 adults in Scotland support that ban. And about 1 in 5 adults say that that would be unacceptable. And the numbers in the middle there are unsure. But slightly over the 2 in 3 adults are of the view that a ban on smoking in the home is something that would be acceptable as a policy. It's actually higher, if I can use my mouse here, and say it's actually higher than the levels of support for raising the age of sale on cigarettes, a measure that we hope is about to go through, along with the rising age of sale that will mean that nobody born after the year of 2009 shall be able to buy cigarettes. So I'd just like to highlight that the levels of the support for a ban on smoking in the home are higher than that measure. So I've just got a few slides here just to also highlight SHS exposure in homes as a result of being employed in an occupation that involves you visiting individuals in their home. So we've done a lot of work here at the University of Stirling looking at that occupational exposure of home health workers. Many of these in the NHS, many of them working in local authorities, and they're involved in the care of individuals in their own home. And so we've made measurements along with individuals over in NHS Lanarkshire who helped us a lot in this work, and we've made measurements of a number of these workers. And the example here is, as you can see, the PM levels, the individuals wearing a monitor, and you can see that in a number of home visits that they experience really quite high exposures as a result of entering into a home where smoking is occurring and SHS levels are high. So that's one example there. Here's another example. And you can see the SHS levels are again up into the hundreds in this case. And if you bear in mind those World Health Organization advisory limits for PM levels, and that no safe level exists for SHS exposure. So that's the measurements made out of 82 visits to homes over in the Lanarkshire area. And as you can see, the mean levels are quite low. So a lot of the visits were to often non-smoking households, and those levels were nice and low. But we do see quite marked, very high levels in some of the visits off to homes where they were visiting individuals who were smoking or other members of the family were smoking. I won't say an awful lot about this. I'm aware of the time. I know that Sheila is going to explain a wee bit more about the bill, but I will just highlight that Section 7 of the bill, as it is at the moment, is likely to have more workplace of the powers, and it could be that the powers are extended there, so we have more smoke and aerosol-free spaces. So let's watch that space. And I'll just really end up, I've just got 2 or 3 more slides left, I think, just to say that we've just had news earlier this week that we've got an editorial that has been accepted. It's going to be out hopefully by the end of March. And a number of us working in this area, so there are 11 authors on this work, and we are making a call here that we are urging all of the governments who are signed up to the World Health Organization's framework, and we're urging all of the governments to have a look at legislation that would mean that it is no longer acceptable that individuals smoke in the home if anybody under the age of 18 is in that home. And also that we're urging that there is the setting of national of the targets, just in the way that Scotland managed back in 2014, setting of national of the targets in order to reduce that exposure. And we think that there should be a framing of the debate around the fact that this is a children's rights issue, emphasising that it's a welfare issue and ensuring that the voice of the child is heard. And we're also asking the World Health Organization if they will modify Article 8 and the guidance around Article 8 in order to make sure that private homes are one of the key environments that we do something around SHS exposure. And really our big aim here is that we want to alter the global social norm and make it unacceptable for smokers to smoke inside the home if anybody under the age of 18 is in that home. So where next? And this really is my last slide. Where next? I think we need to have a bit of a debate. We need to have a discussion about SHS exposure in the home. I want to emphasise again that I'm not saying that bans around outdoor spaces are not a good idea. I think that they are a very good idea, and those outdoor spaces, those bans around hospital entrances, etc., help shift social norms. But I think we do need to be aware that that health, the gains to health as a result of those are going to be quite marginal, and over 96% of SHS that is inhaled in Scotland happens within the home setting. And I would also just like to emphasise that at the moment only 1.5 out of every 100 adults actually smoke inside a home where somebody under the age of 18 lives. So it would actually only impact on a very small fraction of smokers and only a very small fraction of individuals who actively smoke. So last thing I'll just mention there is the Shine network. I'm not going to say very much about it. It's on the slides there, and I guess there's a code there. If anybody's interested in more information about Shine, then we also have a website, and that's at the bottom there. So yeah, I'll stop there. I'm slightly over. I'm slightly over on time, I think. So I'll stop there, Sheila.
Just to make the point, and it came through in the original debate about smoke-free, when we talk about smoke-free, we are talking about the preventable, toxic, health-harming substance tobacco smoke. We are not talking about smokers and smokers' rights. And I think Tom Frieden, the Health Commissioner of New York, which was one of the first locations in the world to move on indoor bans on tobacco smoke, summed it up nicely when he said, "Your right to swing your fist ends where my nose begins." So sometimes there's complex balancing of rights, but really talking about how we can make progress. So Sean will come back to domestic spaces and sort of what we might do and where we might go. But just to fill in some of the background, other things that are being talked about in this. So Sean mentioned the Tobacco and Vapes Bill. It is very imminently, like within weeks, going to go to a stage 3 debate at Westminster. Then it will go to the House of Lords and there'll be further suggested amendments. Then it needs to go to the King to be made law. And then it gets really interesting because there will be a number of consultations. There will be UK-wide consultations on things like e-cigarette flavourings and packaging. And there will be some pieces of the work that will happen at devolved nations level and extending smoke-free spaces and potentially smoke and aerosol-free environments will be subject to consultation in Scotland. And the provisions within that law allow us quite a lot of room to manoeuvre to have those debates. Now, I think it was one of the successes of the original smoke-free. There was a very widespread, heated, engaged debate in the public domain. And that was part of communicating the rationale for the changes, part of people understanding what was being proposed and why, and that it was about dealing with a preventable toxic substance and the health harms on people, some of whom had very little choice about where they were when they were exposed, including bar workers, and as Sean's pointed out, children in spaces where they were exposed. So I think we've heard a good, thorough explanation of the harms of tobacco smoke and the particular levels and concerns of exposure in domestic spaces. And we'll come back to where we might go with that. But I think the Short Life Working Group that Ash Scotland has been leading for the Scottish Government, and that will feed into the thinking both about the consultation in Scotland to enable measures to take forward expansions to what we've got, but also will help inform the 10-year framework. And we're due a new implementation plan in November coming up next year. So this year. So we need, it's a live issue, and it's an issue that we will have some levers of change around. And that is very key to advocacy. You need to have opportunities to put things on the table, to have them debated, to make the case, to look at the evidence and to bring in measures. So in terms of the Short Life Working Group, we're moving towards forming recommendations, which we will share with the government before the end of March, which we will be consulting on and working with the Short Life Working Group and writing up for a report that will be published in June. One of the first ones is the obvious one. It's let's make sure that what we have is working as effectively and efficiently and cost effectively as possible. So the existing legislation, and one of the things we were asked to look at particularly was the implementation of 15-metre smoke-free perimeters as a matter of law around NHS Scotland hospital buildings. How well or otherwise was it brought in? How could we make it work better? And it's at a time when there's very little, if any, spare cash. So we need to make the best of what we have. We need to join up the little pieces of jigsaw in terms of implementation and enforcement. So making what we have work well and making sure that people understand and it's being communicated as part of this. Then there is a big question mark over expanding existing smoke-free provisions in public spaces. So some of that is around outdoor areas like children's playgrounds or public buildings. The areas around schools, should we have a perimeter the way that we have for NHS Scotland hospital buildings? How do we create spaces for children that are smoke-free? And there you get into different sorts of debates. You get into where is the level of exposure that actually harms health? And you get into what sort of society are we presenting to our children as they grow up and to young people? What are we modelling as normal? What are they experiencing that they expect them to adopt as part of their adult lives? And how much are we protecting and supporting people that are trying to quit by removing those visible cues and reminders that this is something that, is nagging at them that they might want to do. And then further, there's a fairly new debate about safe areas, and that's smoke and aerosol-free environments. Now, by aerosol, we mean aerosol particulate matter of the kind that Sean has been measuring in relation to tobacco smoke, but also particularly of the kind that is being measured in relation to air pollution. So we know for certain that e-cigarettes produce aerosol particulates of the kind that create health harm and of the kind that are being monitored in terms of outdoor pollution levels. And we know that they carry toxic chemicals and in some cases heavy metals. Now, anyone that's watched the BBC documentary Toxic Town or the Netflix dramatisation of it will know that this is new emerging area of research, but you can join the dots. You can know for certain there's going to be harm in physical terms from this. And then, of course, you've got all the new recreational nicotine products that the tobacco and related products industries are pushing out there. And they include various varieties of e-cigarettes and variations on that, with a whole range of different contents, most of which are not looked at, not properly researched, not tested. And then you've got heated tobacco products, which the industry will argue don't fall under smoke-free, even though they are tobacco, because they will say, well, it's not burned, so it's different. And then you've got new heated herbal products. So one of the big tobacco companies has bought up a tea company because they want to produce nicotine-infused tea sticks. So they'll argue that doesn't come under the existing regulations. It gets confusing. It confuses people when they don't know where they can use these devices. And it opens up whole new vistas of health harms that will not become fully clear and in focus for decades, because with tobacco, it takes 30 to 60 years to see the really serious disease harms coming through, and similarly with asbestos. So you get the exposure, which is doing damage, and particularly of concern for children whose bodies and lungs are growing and developing, and of concern for those who are vulnerable. And even short-term exposure creates trouble and creates health damage. So Scotland stands on the brink of step changes, potentially. We are going to have the opportunity to consult fairly widely. The industry is going to tell us all kinds of unsupported nonsense, as it always has done, because it is defending its profits and because it can see very clearly where regulation and legislation could create trouble for its future profits. But we need to think now about what sort of world we want the next generation growing up in. We also need to think back to the 50s, when there were very sort of widespread social cues to smoke, when it was advertised very much in television and films, when the health evidence was emerging but wasn't necessarily a settled pattern. By the time you get clear, settled evidence, a whole generation or two is damaged by those substances and that exposure. So we need to be brave in Scotland, and we have been brave in the past. We were one of the first adopters of smoke-free legislation. In Europe, we followed on from Ireland. And worldwide, there were just a few places that adopted it first. I mean, New York, I think, was one of the first city-states to adopt that kind of legislation. And it will feel brave and it will feel risky. And people forget how brave and risky smoke-free felt when we adopted it in Scotland. But it was the right thing to do to protect people's health and to create a safe environment for young people to grow up in. So that is kind of some contextual thinking and updates from me.